Okay, so thank you very much, Lara. It's a pleasure again to be here and speaking to you. I'm going to be talking about gut involvement in EDS and hypermobile spectrum disorder. Most of the patients with both hypermobile EDS and hypermobile spectrum disorder, in my opinion, have very similar gastrointestinal symptoms. And I thought I'd just start by showing you a picture of what the gut looks like. I know that a lot of you would have studied a little bit of science in school, but it was probably a long time ago. So perhaps a good time to just revise what the gut looks like. And the basic thing to say is that it's quite a long tubular structure. It starts just at the mouth, and then you have the throat part, the pharynx, then the esophagus, which is often described as the gullet as well. And then we have this junction between the esophagus and the stomach. And this is important in people who get reflux symptoms, because at this junction there is a valve that opens when we eat and it closes when we stop eating, and that protects us against acid reflux or stomach contents from coming up into the esophagus. Then we have the stomach, and the main function of the stomach is to churn the food, mix it with acid and various other digestive juices to then to change the food into very small particles, which can then go into the small bowel where the absorption of food occurs. The acid also cleans up the food, gets rid of the bacteria, etc. And this is sometimes an issue in people who are taking acid-suppressing medicines, that they can develop symptoms just because lack of acid is not producing the same effect on clearing up the bacteria, etc., that it normally should be doing. The small bowel is where the food gets absorbed. So all the nutrients that your body needs will get absorbed from the lining of the small bowel, but all the waste that you don't need goes into the colon. And by the time that the food arrives in the colon, it's actually still very liquid. So if you were not to absorb some of that water, you would get dehydrated. So the function of the colon, which is a very long tube, is to absorb quite a lot of the water as the stool or the waste goes through, and eventually hard stool will arrive in the rectum when you feel the sensation, and that will lead to an evacuation. So this is really how the gut really works. It's a very simple but elegant structure with different specializations of function in different parts of the gut. And if you actually look at a cross-section of the gut, looking from inside out, you can actually see that if you're looking at from the inside here, this is the lumen of the gut where the food arrives, and these finger-like projections are called the villi, which is where absorption of the food occurs. Okay. And this whole part is also described as the mucosa. These villi have cells which line them, and these cells are very tightly bound to one another, so there are very few gaps between them. So most of the absorption of food actually occurs, apologies for that, here. Most of the absorption of food occurs through the cells. Then just underneath this lining of cells, or the mucosa, is an area called the submucosa, which is very rich in immune cells. And there is also a very rich nerve supply called the submucous plexus. And then after that, you have two muscle layers. You've got an inner circular layer and an outer longitudinal layer. And between the two muscle layers, there's another plexus of nerves called the myenteric plexus. So the gut has a lot of immune cells because it has to protect you from all the things that you're consuming, all the medicines that you take, etc. So the immune system is there to protect you, and then it has a lot of nerves in it as well. And in fact, the enteric nervous system, as it's often called, has as many nerves as the spinal cord, which is something that we often forget. If we now look at it further in a histological way, that we take a cross-section against through the muscle layers of the gut and stain it for connective tissue, what we see is that if you look at this is the outer longitudinal muscle, this is the inner circular muscle, and in between the two are the nerves, the myenteric plexus. You see these connective tissue scaffolds that are coming down, these dark maroon bands that are coming down. And then there are a lot of collagen and elastin fibers, and interestingly, a lot of these collagen and elastin fibers are around the nerves of the enteric nervous system. So there is now reason to believe that there is an interaction between these connective tissue fibers and the nervous system as well that may partly be responsible for some of the symptoms that our patients experience. And it was really Dr. Alan Hakim and Professor Rodney Graham who first described that in EDS patients, gastrointestinal symptoms can occur. They did a survey in their patients and looked at the range of symptoms that these patients can experience and identified that those who had EDS, which was previously used to be called joint hypermobility syndrome, had more gastrointestinal symptoms in comparison to healthy controls. So gut problems in EDS can, I think, be classified into three main areas: mechanical problems of the gut, sensitivity of the gut, and there is a question mark about whether this gut may also be leaky. And I'll talk you through these problems as we go along. So looking at the mechanical problems in the gut, and I think the theory, and remains a theory and a hypothesis, just like Satish was saying, that things have not really been proven in pots. In the same way, things have not really been proven, but this is one of the hypotheses that, the gut is a tubular structure, as I showed you. And if it is more elastic and stretchy, because the collagen is more elastic and stretchy, it may be a bit more floppy. And we know that flow in a tube depends on how elastic it is. So the more rigid a tube, the faster the flow. And hence, when you actually open the tap in your kitchen, you actually see that the water flows out quite rapidly. And if you have one of these old-fashioned hose pipes, you actually see that the water force with which it comes through is a lot less. And that's because the hose pipe is made of rubber and is more elastic. So you would imagine that if a gut is more elastic and stretchy, it would be a bit slow. So while we have evidence, especially in the colon, that the gut is slow, in the stomach, we get both increased movements and slow movements as well. And this weakness could be just because the gut is more connective tissue is elastic, but there is some evidence to suggest, as I mentioned to you earlier, that there may be problems in the nerves and the muscles as well in these patients, and how these nerves and muscles interact with the connective tissue. So what symptoms do we get? We get symptoms of acid reflux. So patients have burning discomfort in the chest. Reflux is perhaps one of the most common symptoms that we find. And it's not always that we find that the esophagus is actually inflamed or injured. Quite often, patients get reflux symptoms even though there is no inflammation. So it's often described as non-erosive reflux disease. And we also find that a lot of our patients with hypermobile EDS have a very sensitive esophagus. They may get normal levels of reflux acid coming up, but they're very sensitive to it. Whereas another person may not feel any symptoms, they feel it much more severely. Then we also see swallowing problems, and we see swallowing problems related to the fact that the esophagus is a bit sluggish, because when we eat, we have peristalsis, which is squeezing movements of the esophagus, which squeeze the food down. And if the esophagus is a bit weak, which we often see in our patients, then that will mean that the food going down the esophagus is a bit slow, and you might feel that it's actually sticking there. There is a small group of patients who also have problems in the throat part of the swallowing, the pharynx here, and they appear to have a sluggishness there, and they get pooling of food in the spaces in the throat, which can also give them a feeling of difficulty with swallowing. And a lot of our patients overlap with these functional gut disorders. So these are disorders which are classically said not to have any pathological or well-defined cause. But we found that about 50% of the patients who get a diagnosis of functional dyspepsia, which is indigestion symptoms not caused by ulcer or Helicobacter pylori or any other cause, about 50% of these patients meet the criteria for hypermobile EDS. So the sort of symptoms that you might get is pain in the upper part of the tummy, often described as epigastric pain. This is really the uppermost part of the tummy in the middle, and this can often be described as a burning discomfort. Nausea is a particularly common symptom, especially after meals, and occasionally there'll be vomiting, but that's less common in functional dyspepsia. a band-like sensation around the abdomen, that there's tightness there. They can't eat very well. They get full very quickly and are not able to finish their normal meal size. And bloating is a very, very common symptom that we see in our patients as well. We also see that in some patients, as I said, the stomach, which is shown over here, this is basically food in the stomach, and this is the pylorus, which is where there is a valve which allows the food to empty into the small bowel, which is called the duodenum. So the food goes through at a specific certain speed from the stomach to your small bowel. But in some patients, we see that the stomach is slow, and in other patients, particularly that overlap with POTS, we have a subgroup of patients in whom we actually see the stomach emptying is very rapid. And I think that contributes to some of the symptoms that patients get with POTS, like the after meal drowsiness, dizziness, etc. And I'll come back to that a little bit later. At the moment, we can't predict who's going to have fast emptying or slow emptying, but the only predictor appears to be this overlap with POTS. But not every patient with POTS has rapid gastric emptying either. So there's quite a lot of work to be done. Constipation, again, is a common problem, and we certainly find that the colon is often sluggish in our patients. So this is a marker study where the subjects have been given 50 radiopaque markers to swallow, and you then take an X-ray 5 days later, and 5 days later you can see on the left side of the bowel of the colon that all these markers are stacked up, showing that they have not cleared up even in 5 days, and that's the definition of slow transit through the colon. We also see anatomical problems in the pelvic floor in our patients. So quite often, this is the rectum over here, and sometimes we see this sagging of the rectum towards the vagina, something which is called a rectocele. So it's almost like a pouch that actually forms in the rectum, which can press on the vagina. And sometimes we also see what we call intussusception, that the rectum collapses on itself. So instead of squeezing the stool out, it flops down on itself, and sometimes that leads to a frank prolapse as well. So these problems appear to be more common in hypermobile EDS patients. So whenever there is a sluggish gut is not moving very well, there is stagnation that occurs in the gut, and it's a closed system. There's food, fluid, stool all mixed in together, and therefore you will get fermentation. So it'll become like a pond. It should be like flow, it should flow like a river. Okay, so you should be emptying your bowel regularly. But if you're not doing that, and you haven't had a bowel movement for up to a week or so, there is a lot of stagnation that goes on inside. And that stagnation will lead to unhealthy bacteria growing in the gut. The gut has millions of bacteria, but in this situation now, you will get, these are normally healthy bacteria, you start to get unhealthy bacteria growing there, and they start to ferment the food, particularly carbohydrates, particularly fermentable carbohydrates, often described as FODMAPs, and that leads to quite a lot of symptoms. You can get bloating, you can get pain, tightness, flatulence. A lot of symptoms can occur due to bacterial overgrowth. The sensitive gut, the gut has a lot of nerves, as I've mentioned to you. These nerves in the gut communicate with the brain through a number of nerves, but it has been described in hypermobile EDS patients that the nerves can get easily sensitized in the skin, joints, etc. And it seems to be the same thing in the gut, that the gut appears to be very sensitive. You know, some of our patients have difficulty with eating and they go on to enteral nutrition. They can't even tolerate 5 mils, 10 mils of fluid going down the small bowel. So it's a very, very sensitive gut that we find in our patients. And this sensitivity can be due to sensitization that occurs at the level of the gut. It can be due to central sensitization at the level of the spinal cord. And then the psychological stress, anxiety also has an influence on that, because there are these descending inhibitory pathways that are supposed to inhibit pain, and these pathways are less active than if you're stressed and so on. And the combination of these factors can make the gut very, very sensitive. And I just want to touch on another factor that we see in our patients with hypermobile EDS. We've just had a poster presented on this at the Digestive Diseases Week of the American Gastroenterology Association. I've been noticing in my clinic that a lot of patients that we see with chronic pain, chronic abdominal pain, have got a abdominal wall pain, that the pain is not actually coming from the gut, but it's actually coming from the muscles on the abdominal wall. So we've done a little study on this and found that, particularly in our patients with hypermobile EDS, a lot of patients have trigger points on the muscles of the abdominal wall. This presents as constant pain, 24/7 pain, pain on movement, pain on change in posture. And what often happens is that you can see that the muscle in the middle, on the right side it's been cut, but on the left side, this muscle here in the middle is called the rectus muscle. This is the muscle that you go to the gym and try and get a six-pack on your tummy. But through this muscle, there are a number of nerves that come through, these little white cords that are coming through. There's 6 of them come out at every 6 centimeter interval. And these nerves can get trapped. So these are called anterior cutaneous nerves. So this is the nerve, the white cord that is going through over here. This is the nerve then goes through a fibrous canal in the muscle, and there it can get trapped. You can get a nerve entrapment, and that will cause severe pain. And it'll be neuropathic pain, it'll be a burning pain, and it'll be constantly there. And we found that very common. It can be treated. You can inject this area with a bit of local anesthetic and steroid. There are conservative measures that you can take as well for this. And this is something to look out for in our patients, and we'll be studying this a lot more systematically as we go along, because it's a completely treatable condition. Leaky gut. I told you that the lining of the small bowel, lining of the gut, basically has a lot of cells. And these cells are very tightly bound to one another. There are no spaces between these cells. But for a variety of reasons, when the gut is inflamed, it's injured, you've had bacterial overgrowth, the gut immune system is not healthy, the gut becomes leaky. These cells, the gaps open up between these cells, and unregulated food, drugs, a whole range of particles that are there in the gut, bacteria, will get through the gut. And that will activate the immune system even further that is trying to protect you. And that's where the mast cells will get activated. But this is known to be the basis for food allergy, food intolerances, autoimmunity, and then you get a lot of inflammatory proteins circulating around that go through your blood to the brain and cross the blood-brain barrier, and they can cause fatigue and so on. So this is something to look out for. This again remains a hypothesis at this stage, but I think a very plausible hypothesis, because we know that a lot of our patients have irritable bowel syndrome type of symptoms, and the vast majority of studies that have been done in irritable bowel syndrome show that the gut is very leaky. And of course, mast cell activation disorder could be based on that if you've got a lot of mast cells activated in the gut because of a leaky gut, then you'll get a lot of these gastrointestinal symptoms of diarrhea, abdominal pain, cramping, meteorism, which is a lot of severe flatulence, etc. Very quickly about the link between POTS and the gastrointestinal symptoms. A lot of our patients with POTS describe that they get a bit tired and a bit drowsy after their meals, and some of them have more extreme symptoms. They get dizzy, and very extreme symptoms is a small minority who say we can't actually sit upright, we have to lie down, and some of them actually faint. So the theory again remains to be proven, but when we eat, there's increase in blood flow in the gut. That's why a lot of moms say to their kids, don't run after you eat. So that increase in blood flow could potentially, because you're running on a system where you have POTS, your blood pressure is a bit on the low side and your vascular volume may be a little bit on the low side, you can get symptoms because of blood that is trapped in the blood vessels in the gastrointestinal tract, and all the same symptoms of POTS can be triggered potentially by that. But there is another mechanism why patients with POTS can get symptoms, and I said the stomach emptying can be more rapid in some of our patients. And as you can see, that sometimes this rapid stomach emptying can dump the food very quickly down into the small bowel, and particularly carbohydrates and sugars. When they come down into the small bowel very rapidly, the concentration of fluid in the small bowel is very high, whereas the concentration of the fluid in the blood vessels is low. And you get a fluid shift through a process called osmosis, again going back to your science lessons, that fluid moves from the blood vessels into the tummy cavity to neutralize this high concentration of fluid, and that causes a reduction in vascular volume, and the POTS symptoms can be triggered. So this could be another mechanism as well. So coming quickly to the management, so just telling our patients that we think we know what causes your symptoms, that you have hypermobile EDS that is linked with gastrointestinal symptoms. We have a lot of studies now that show this association. That makes a difference, because a lot of these patients have been told that we can't really understand what causes your symptoms. It may be all in the mind, you have irritable bowel syndrome, et cetera, et cetera. A multidisciplinary approach is important, and I think it's very important for us to work in teams where we have dietitians, pain management specialists, and other consultants, other specialists that you can refer to for patients who have overlap with POTS, joint problems, urinary symptoms, and so on. And of course, these chronic long-term symptoms do produce anxiety and stress, and in some of the patients, having a close association with a psychologist is actually helpful. We have to exclude organic diseases because some of these organic diseases do overlap with hypermobile EDS. There are studies which show that incidence of inflammatory bowel disease like celiac and Crohn's disease is higher, celiac disease incidence is higher, autoimmune connective tissue disorder incidence is higher. So these conditions do need to be excluded, and just the fact that you have hypermobile EDS doesn't mean that you cannot have one of these conditions as well. And we normally do a lot of studies on gut function, on gut physiology. These are not the abnormalities, the symptoms are not going to be diagnosed by doing structural tests like x-rays and scans and so on. These are tests on gut physiology and motility, where you can measure esophageal motility, for instance, stomach emptying test, hydrogen methane breath test for bacterial overgrowth, colonic transit studies, anorectal physiology studies, etc. Whole range of physiological tests on the gut are required. And food intolerance is quite a common problem in our patients, as you would imagine from the range of things that I've actually discussed already. And in some of our patients, as I said, if you have bacterial overgrowth in particular, in POTS patients, for instance, these fermentable carbohydrates called FODMAPs appear to be a problem. And in the early stages when we were, and this is a diet which is highly recommended in irritable bowel syndrome patients, we recommended it to some of our patients, and what we were surprised was that they were coming back with improvement in not just the gut symptoms, but other symptoms. The brain fog was improving, the tiredness, fatigue was improving, the POTS symptoms were improving, etc. So this raised our interest in the role of diet quite significantly, and there was a group of patients who seemed to be on low histamine diets, and they seemed to be getting better, especially in those who had mast cell activation type of symptoms. And some of these patients go on to antihistamines and mast cell stabilizers as well, which helps to reduce their gastrointestinal symptoms. So working with Lisa Jameson, who's a colleague of mine, who's originally a trained senior pharmacist, but now she's retrained as a nutrition specialist, just in a master's. We're working on developing a diet specifically for hypermobile EDS patients through all the experience that we've gained over the years and a lot of Lisa's personal experience. And we're currently doing this fundraising campaign, and I'd just like to thank a lot of you who have contributed to that. You might want to look at it at the website, EDS website, if you haven't come across this yet. But we're almost there, and we hope to be starting this trial around September. In POTS patients, we often say those with rapid gastric emptying and those who develop, there's another condition called postprandial hypoglycemia, when your blood sugar can go low. We say eat small frequent meals, opt for low glycemic index foods, not very highly sugary sweet foods, increase fat and protein because that slows stomach emptying down, avoid liquids half an hour before and after meals so that you don't flush all your carbohydrates down into your small bowel very quickly. Lie down for 30 minutes after a meal reduces some of the symptoms, and increase your salt and water intake. Some of this is standard sort of advice that POTS patients get. And in some of these patients, by just improving their general POTS symptoms by fluorocortisone, midodrine can help, but occasionally when we see patients who are getting a lot of food-related symptoms, octreotide, which is a hormonal treatment which increases the vascular resistance in the blood vessels in the gut, but also slows down stomach emptying, can sometimes be quite helpful. These are the patients who are fainting after meals, etc., where octreotide can be quite helpful. Enteral and parenteral nutrition are sometimes necessary because there is intestinal failure, but sadly, the failure rate of these types of treatments is also quite high. Infections are common. Pain, especially those who are getting fed directly into the gut, is also quite a common feature. And this is something we're working on. There is a working party now in the UK, which includes a lot of nutrition specialists that are working to develop some guidelines around this just to see what the issues are and what the best practice should be. But in these patients, it's often worthwhile thinking about POTS, mast cell activation disorder, abdominal wall pain, small intestinal bacterial overgrowth, because attention to some of these can sometimes improve their nutrition, and psychological issues like anxiety, depression, etc. needs to be managed. And there is a very, very small group of patients where there is an overlap with eating disorders, and this needs to be understood and dealt with. Avoid opioid painkillers because they'll slow your gut down even further, so that's important to try and avoid them as much as possible. And there are drugs, of course, that reduce sensitivity. These are called pain modulators like gabapentinoids, amitriptyline, SNRIs like duloxetine, etc., that desensitize your nerves in the gut. These are considered to be very useful in some of our patients, but the central sensitization, especially psychological stress, etc., through psychological therapy like CBT, hypnotherapy, slow deep breathing, SSRIs can also be helpful. For constipations, keep the stool soft through the diet, like prunes, etc., although they can cause bloating. Pegylated solutions like Movicol to soften the stools, sometimes in addition with stimulant laxatives like Senecot and Dulcolax, and prokinetics. In the UK, we get Resolor, which is a prokinetic drug which stimulates the colon to produce better emptying. And of course, sometimes you have to improve your rectal evacuation by suppositories and so on, and biofeedback and surgery is sometimes necessary. In those with a lot of problems with bacterial overgrowth type of symptoms, sometimes after we treat it with a antibiotic, we can recommend probiotics, and often low FODMAP diet often helps to reduce the incidence of bacterial overgrowth in some of the patients that we experience. So just to summarize, we know that EDS is a multisystemic condition, and therefore we need a multidisciplinary team to really manage these patients, and we need to look at, in the UK particularly, at commissioned services which do not exist there at the moment. And just remains for me to thank all the colleagues who've worked very hard to try and get us where we are, and especially the Ehlers-Danlos Society and EDS support group in the UK. Thank you very much.